Hello, everyone, and welcome. My name is Sandeep Nathan. I'm an interventional cardiologist at the University of Chicago, and it's my absolute pleasure to moderate tonight's discussion titled Transforming STEMI Care, Bridging Interventional and Heart Failure Cardiology to Improve Patient Outcomes. As I said, I'm an interventional cardiologist practicing at the University of Chicago, and I'm joined this evening by an all-star cast of academic cardiologists from across the country, all friends, all folks that I've worked with many times before, and it's a delight to be with everyone tonight. So before we get any further, let me take this opportunity to introduce the panelists and speakers this morning. Dr. Dan Burkhoff is currently the Director of Heart Failure and Hemodynamics and Mechanical Circulatory Support Research at the Cardiovascular Research Foundation in New York, New York. Welcome, Dan. Great to see you as always. Dr. Jerry Estep is a cardiologist at the Cleveland Clinic, Florida, in Weston, Florida, where he also serves as the head of the section of heart failure and transplantation. Welcome, Jerry. Dr. Marat Foudim is an assistant professor of medicine at Duke University Medical Center, where he's an advanced heart failure cardiologist. Welcome, Marat. Dr. Suzanne Barron is an interventional cardiologist at the Massachusetts General Hospital in Boston, Massachusetts. Great to see you, Suzanne. Thanks for joining us. And Dr. Michael Lim is an interventional cardiologist in St. Louis, Missouri, in practice for well over 20 years and involved in all things academic related to STEMI. Welcome, Michael. Thanks for joining, everyone. The purpose of today's webinar is to discuss as a group how we can move the needle on outcomes in patients with ST segment elevation myocardial infarction. I think we regard STEMI and acute coronary syndromes as a problem, certainly, but one that we've already found solutions for. We're very good at opening up vessels, even in the middle of the night. And so what's there really to talk about? Over the course of the next 45 to 50 minutes, I think you'll see, however, that there are many things that we can do to improve outcomes in cardiovascular care for STEMI patients. The purpose really of this evening's fireside chat is also to highlight the collaboration that's possible between interventional cardiology and heart failure specialists in managing these patients. And rather than approaching this in a silo, think about ways in which we can meaningfully improve outcomes for these patients. As I've already alluded to, this is really meant to be a conversation, not a lecture per se. We will have some slides woven through the presentation, but I would encourage everyone that's on this call to go ahead and send in their questions through the chat, and we'll try to get to as many of them as possible. I'm going to turn it over to Marat to kick us off here with a discussion of STEMI in heart failure and really talk about the prognosis of this patients, because I think we have to sort of level set our expectations in terms of what we're actually doing for these patients in order to understand how best we can help them with novel therapies that we'll discuss today. So with that, I'm going to turn it over to Marat.
Thank you very much for the introduction. And so I was asked to talk about heart failure epidemic in ST-Elevation MI. Notably, this talk is supported by Zoll/Therox. That's the one notable disclosure. So let's talk about the goals of the presentation. Just 10, 12 minutes of talking here, and then we can go into the discussion. So I hope to define the burden of heart failure in the current year of 2023 and highlight the implications of STEMI on heart failure outcomes. Something we do often see, but maybe not always talk openly about, and then provide clinical risk factors associated with heart failure post-MI, and review concept of an early intervention where we might actually modify the disease state. So the burden of heart failure is actually overwhelming. It is the #1 cause of hospitalization in the United States, unless you consider childbirth to be a disease state, which is just a lot more frequent than heart failure. But it amounts to 6.7 million hospitalization for heart failure in the United States alone. We think that about 2 to 3% of US adults have heart failure. And as you see on the right side here, marked with a box in red, is that, once you're above age of 60, 70, that ranges between 7 to 10% for the prevalence of heart failure in the US population. The number will go up to 9 million by year 2050 alone. And as you can imagine, that also constitutes one of the most costly diseases for the healthcare system in the United States. Well, when we think about causes of heart failure, well, ischemic heart failure is certainly the most common cause of heart failure, and specifically in heart failure with reduced ejection fraction, ischemia and coronary disease tends to be the most common and driving force. And that also extends to sudden cardiac death, where ischemic disease or coronary disease is the predominant cause of sudden cardiac death. So we will probably touch upon in discussion later. We have this great interventionalists on this call when we have made such great strides in the last 10, 20, 30 years in improving our STEMI outcomes. But that really is speaking to certain components of CAD and STEMI care. But if you look here in the blue and green, the actual mortality post-STEMI has remained unchanged in the last 20 years. And sadly, the same thing is true for heart failure incidence in the 2 years post-initial STEMI, as you see around 20%, no matter which year we're looking at. And to make things worse, if you take, for example, in this study, a population of 65-year-olds that had their first acute MI, if you look at what is the incidence of heart failure developed in the hospital, that was around 34, 35% for in-hospital heart failure incidence. But if you look all the way out to 5 years, there's a staggering 71% of incidence rate of heart failure development in the 5 years following a STEMI. So it's more likely that you develop heart failure than not once you had an actual ST-Elevation MI. And this interesting publication from Stone really shows the following. First of all, about 50% of patients post-PCI STEMI had actually an infarct size of at least 18%. If you do the math further, 25% of patients had an infarct size of greater than 30%. An interesting thing here is that about the relationship of the scar burden with all-cause mortality or heart failure hospitalization, and it's linear. A doubling of the scar size is associated with the doubling of the risk for heart failure hospitalization or death in the subsequent 1 to 2 years. But we often focus, and I have not been in training that long ago, and we really focus a lot on the epicardial vessels. Those are the vessels that we obviously target with our PCI procedures, but we often forget about the microvascular disease, which is really the 90% of the vasculature that supplies the heart with blood. Yet, the microvascular dysfunction is associated linearly with the infarct size itself. So the more scar you have, makes sense. There's also more microvascular obstruction following an ST-Elevation MI. The interesting thing is that the burden of microvascular obstruction here, MVO, is associated not only with the infarct size itself, but the greater the degree of microvascular obstruction, the greater degree of all-cause mortality and heart failure hospitalization, similar to the paper I just showed you earlier from Greg Stone. This is from a pooled analysis of 7 clinical trials where microvascular obstruction was measured using MRI. We'll maybe get to that later, but you can measure microvascular obstruction using many different techniques, and MRI is one of those techniques. So if you do the math in this meta-analysis, 60% of patients had evidence on MRI of microvascular obstruction following ST-Elevation MI. And I'm showing you data that the more the MVO burden, the higher the rate of death and heart failure hospitalization. So then 6 studies were pooled together where microvascular obstruction was measured various different techniques. It was actually not MRI-based. Pressure gradients were measured and then measured ultrasound-based flow. And what they found is that if you had a significant degree of microvascular obstruction following an MI, you had a 3.4 higher risk of MACE, major adverse cardiovascular events, following PCI in the subsequent 1 to 2 years. So a staggering amount of risk following an MI in the presence of microvascular disease. So what does what does the STEMI predispose you at risk? What puts you at risk for? Well, first of all, we talked about heart failure quite a bit. Of course, it can cause to death. It can lead to stroke. But today we will primarily focus on heart failure. And heart failure is important, as I told you earlier, the burden of heart failure is very high following a STEMI. The costs of heart failure are very high. And when we think of heart failure post-MI, there are really 3 scenarios in which you can develop heart failure. You can develop heart failure right then and there in the setting of a STEMI while he's still in a cath lab. You can develop heart failure during the index hospitalization, days later, or after discharge, as I told you, all the way up to 5 years, with the risk being above 70%. The important thing is that all of these patients will be at increased risk for progressive pump failure. And maybe it's two very important statistics to take away from today's mini lecture here is 20 to 30% of patients have the risk of heart failure incidents following a ST elevation MI is 20 to 30% at the first year and 71% at 5 years. Importantly, once you develop a heart failure, for example, heart failure hospitalization, whether it's related to a STEMI or not, the risk of subsequent death is about 50 to 60% at 3 to 4 years, as shown by this publication by Shah and colleagues. So how can we predict the heart failure onset following an MI? Well, there's certain biomarkers that give us a good idea that you might actually develop heart failure, symptomatic heart failure following the STEMI. Well, first of all, we talk about infarct size. The greater the degree of infarct size, the more wall stress you have. If you measure the pressures right after the cath procedure, the more pressures, the more inflammation, you would probably get a good idea that this patient is heading towards heart failure. Then, of course, if the patient has evidence of systolic dysfunction right then and there on the table, that might not be symptomatic in the beginning, but very likely going to lead to symptomatic disease down the line, but also microvascular obstruction, as we've discussed now a couple of times. And there are clinical risk factors that predispose you to a greater degree of incident heart failure following ST elevation MI. That includes age, female sex, interestingly, as well as comorbid disease, to no surprise, such as diabetes and bad renal function. So what are we going to do with all this information? How do we put it all together? Well, hopefully I demonstrated to you that many factors predispose to the incidence of heart failure, but one of them that we often overlook, because up until recently we actually know treatment options for this, is actually microvascular obstruction or microvascular dysfunction. I would argue that once targeting microvascular obstruction, you could actually improve perfusion to the heart. You could potentially prevent LV remodeling, prevent systolic dysfunction, and hopefully then prevent the onset of systolic heart failure, and even maybe diastolic heart failure, something we might want to touch upon later as well. And then, very importantly, is that we often are quite reactionary in the space of cardiovascular medicine and medicine in general. And I think it's important that we don't lose track of the fact that if we are able to act upon microvascular obstruction early, we might actually prevent the onset of heart failure, systolic or diastolic heart failure, by targeting this process early in this case in the development of a ST elevation MI, rather than wait for it to occur. Because I demonstrated to you, once you have an incident heart failure event, for example, heart failure hospitalization, now the risk of rehospitalization is ridiculously high, and the rate of death is 50 to 60% at 3 to 4 years out. So an early intervention is certainly of importance. Why? Because if you intervene early, you could actually decrease the burden of heart failure. This will, of course, result in a reduction of the cost burden to the system. And Sandeep actually made a very important point. This is not a one man or one woman show. This is something that we as a team, cardiologists, interventionalists, heart failure, even the staff in the cath lab, where all we have to pull together our heads to try to think of a patient in a continuum. Rather, this patient is now in a cath lab. Now it's the patient is going home and is going to be at some point a cardiology or heart failure patient. I think we have to think of this as a continuum, and prevention will always beat the dealing with a heart failure later as a standalone disease. Take home points. Heart failure is very prevalent, and unfortunately, despite all the recent contemporary efforts, remains a very common and frequent incidence. We have not made a dent in the incidence of heart failure following ST elevation MI. The risk is about 1 in 4, 1 in 5 patients in the first year following ST elevation MI. And I do think there's a lot of opportunities to improve upon those outcomes. I think one of the steps, hopefully talking about this now, and up until recently, we really have not talked a lot about microvascular obstruction. First of all, it's not that straightforward to measure or to diagnose microvascular obstruction. And most importantly, we didn't have therapies for it up until recently. And I think we will be touching upon supersaturated oxygen here in the subsequent discussion. But by having a therapy now, we maybe can talk about it more, educate ourselves more about this topic, and then hopefully improve outcomes. Thank you very much for your attention. I look forward to the discussion.
Well, that was a fantastic talk, Murat. Thank you for getting us started there. There's a lot to discuss. Let me put this to everybody on the panel. How does this notion of 1 in 5 STEMI patients going on to have heart failure, how does that resonate with everybody? Because I think that in practices where perhaps we don't necessarily see all the cases that we do, Suzanne, Mike, I think there's this notion that patients do really well, but it's our heart failure colleagues that often end up seeing these folks, not necessarily us in clinic. So how does this concept and the microvascular dysfunction concept resonate with everyone? Dan or Jerry, is this does this sort of square with what you guys see when we've sort of left the cath lab and handed these folks over to you?
Yeah, I think the issue is, as you said it, the heart failure physicians see these patients, and we don't really think too much about what happened in the cath lab. On the other hand, I think the interventional cardiologists see the patients in the cath lab and don't think a huge amount about what happens, 1 month, 3 months, 6 months afterwards. And that's maybe where the disconnect is. And we have to bring, as Murat was saying, we have to bring together the continuum of care and make the interventionalists, help the interventionalists think about what's happening down a lot down the line. So maybe Michael or Suzanne can comment, do you think about what's going to be happening 6 months later?
And no, I mean, I think that's a really important point. We really do look at this as, an episode of care. We get the vessel open, we all high five in the cath lab, and everybody feels great. And I think what we really do need to be thinking about is exactly what everybody's saying here, that this is, we think about it. I'm also a structuralist, and I think about the lifetime management of valvular disease. I think when I see a patient having a STEMI, and even if it's in 2 in the morning, we have to start thinking about these patients as a lifetime management and what's happening down the road, not just getting them through the episode of care, either whether that's just, the hour that they're in the cath lab or even just their index hospitalization.
I think another point.
Older,
I think another point.
Go ahead, Dan.
I was just going to say another point is up until now, we haven't given the interventional cardiologists a lot to think about other than get that vessel open. And what we now have are, is SSO2 that has been shown in, multiple studies and also in preclinical studies to markedly reduce infarct size. So, that's where we have to educate the interventional community to recognize that this is a problem and there is something that you can do and think a little bit more long-term for this patient, like you just said, Suzanne, about, the lifetime care of this patient. Michael, you had a comment?
Yeah, I was just going to say, maybe I'm a little bit older, but the concept of having 0% residual stenosis and the so-called TIMI3 flow in the coronary artery has not been my sole focus as an interventionalist in STEMI management. I have tried to think about infarct size. We have had things to add, like a eplerenone after the Ephesus trial. And if the interventionalist didn't actually start that or put that on the post-cath order set, it didn't end up happening. That was something I thought was really important to try to preserve and have as much ejection fraction as possible at 30 days afterwards. There have been other times where, the ACE inhibitors and the other things that we can add in addition to that are just as important as the dual antiplatelet therapy and a good job with the stent. So, the interventionalist mindset is I think, it depends. Certainly the door to balloon time project that went across the country to really not just say we have to open up the artery, but we have to open it up in a timely fashion, certainly narrowed that focus down. And I think Suzanne represented, one of the effects of that. Now it's time to just kind of broaden our focus back out and say, well, okay, let's do that fast, but what else is there, as you just alluded to, Dan, like, SuperSaturated Oxygen, other potential therapies down the road to get rid of this heart failure burden and try to have our patients do better.
And I think that's a perfect segue, Michael, to a couple of slides that I want to share with you guys to sort of punctuate the points that Murat very eloquently made. I'm going to go ahead and share with you guys a couple of slides here. When we are perseverating about plaque shift, thrombus, and embolization, compromise into a septal perforator or the second or third diagonal. It doesn't matter how detailed we get in our intervention, we're still focusing on 10% of the coronary circulation. The vast majority of the coronary circulation is actually in the downstream microvasculature. And so whereas we really turn our eyes to the epicardial vessel stent optimization, did we do intravascular imaging, did we size the stent appropriately, and so forth, do we have side branch preservation, 90% of myocardial blood flow is still supplied by the coronary microcirculation. This is not a new concept because there have been so many attempts over decades, really, clinical trials that have looked at ways to reduce infarct size by targeting the microvasculature, either through mechanical interventions and device-based therapies. You can see here distal embolic protection, thrombectomy in many different flavors, therapeutic hypothermia, medications and antiplatelets, intensification of antiplatelet therapy. When glycoprotein inhibitors were being used frequently in the 90s and early 2000s, I think there was a sort of a stated hope that that this would be one of the magic bullets that helps reduce infarct size, in addition to timely reperfusion of that infarct-related artery. There have been numerous other novel agents that have targeted free radical injury and mechanisms and pathways for inflammation. But pretty much everything that you see on this slide, and then some, including Pixo, has failed to hit the mark in terms of meaningful and reproducible reductions in infarct size. But hope springs eternal, and there are still trials that are ongoing. I put one at the bottom of the slide. Ioside AMI3 is being planned with this sodium iodine analog for reduction in inflammation. But we'll just have to see. I will talk in just a few minutes about SSO2, which has already been brought up by multiple panelists as something that we have right now to actually reduce infarct size. So I'm going to stop sharing my screen here, and I'm going to put it to my interventional colleagues. When you're in the cath lab and you're dealing with a thrombosed LAD, how do you approach it, and what are your metrics of success in terms of microvasculature? Do you even think about microvasculature in the moment, unless you've got overtly sluggish flow? What do you do now when you actually see perhaps a suboptimal result? Michael or Suzanne, what do you have sort of a an algorithm in your head, or do you use vasodilators? What do you do? I mean, the horse is sort of out of the barn once you put that stent up and your microvasculature is not behaving.
Well, I'll give the historical perspective, right? The glycoprotein 2B3 inhibitors were the things that we relied on during my fellowship training and early in practice, because we thought that would get rid of platelet plugging and the microthrombi that went down into the microvascular space. Mike Gibson just put out a tweet, I think yesterday or the day before, reminding all of us that, we say the patient has TIMI3 flow down the coronary artery, but the actual tissue perfusion, when we measure it with more detailed means, is far from satisfactory. And so even when we don't get no reflow, we're not necessarily getting true tissue perfusion. What you're alluding to, Sandeep, is when we get no reflow. So what do? I think that was the whole reason why, aspiration thrombectomy was really in vogue. Everybody wanted to do it. Like, that thrombus has to be bad. Let's get rid of it. It's still fairly common, not recommended to be routine, but fairly common, especially in large thrombus burden. But then when you get no reflow after that, you throw the kitchen sink at it. And we come up with off-label things like intercoronary 2B3As, intercoronary lytics, intercoronary vasodilators, you name it. We try it because we're just trying to do anything. But I think you already said it. The cat's out of the bag. Sorry to cut you off, Suzanne. You can go ahead.
No, I 100% agree with what you're saying. And you're right. Everything that we're looking at to try to treat once we hit that no reflow situation, or even just sluggish flow, what we're looking at are all pharmacologic means, whether those are systemic or they're intracoronary. And, you know, I think we've all been in that situation where despite throwing, as you said, the kitchen sink at it, you still have suboptimal flow distally after you've, you know, put a well-sized, you know, intravascularly imaging optimized stent in.
So I think implicit in all of those comments, and you know, I completely agree, implicit in all of those comments is that we actually care about the microvasculature, and we recognize when things are going badly that this is going to turn out poorly for the patient in terms of clinical outcomes. But you know, all of those strategies are really reactive strategies, and at every single TCT I've ever attended for the past 20 years, there's a sort of a line of posters of magic combinations of various cocktails for improving flow in the epicardial vessel once you've already embolized or have some evidence of impaired flow. I think that we need to pivot now and think more about this in a proactive fashion. And so I'd like to share my first slide here, sort of introducing SSO2, which is has been approved for a couple of years, but then this little thing called the pandemic happened, and you know, we really didn't get to see the full potential of this therapy. Shown on this slide is the basic concept for Therox supersaturated oxygen therapy, FDA approved a couple of years ago, as I said, and slowly gaining traction in the United States and hopefully the world over. The concept is simple. Oxygenated blood is removed from the femoral artery. It's mixed with supersaturated O2, basically aqueous O2, in a fixed ratio, and then reinfused into the culprit vessel. The FDA approval is for ST-Elevation Myocardial Infarction within 6 hours of symptom onset in the LAD territory. That's not to say that this couldn't work in other territories. The AMI-HOT-1 study was inclusive of anterior STEMIs as well as large inferior STEMIs, but this is what the FDA indication is. And so there is a draw line that takes blood out, runs it through this cartridge that saturates the blood to about 7 to 10 times the normal saturation of O2, and then reinfuses it in a manner that ensures that there's no bubble nucleation. Simply stated, the O2 doesn't bubble out of the blood. And the mechanism of action, the mechanisms of action, is essentially restoring normoxemic or hyperoxemic conditions to the infarct zone and the ischemic penumbra of an anterior STEMI that's independent of RBC traffic. Everyone recognizes that there's microvascular obstruction that occurs for a variety of reasons, and there are within a territory that looks normal in preclinical models, normal by angiography. There are hypoperfused zones pretty much everywhere. There's patchy areas of hypoperfusion, and the idea behind SSO2 is to restore O2 delivery to ischemic myocytes via plasma diffusion, and also to reduce capillary endothelial edema to restore the normal flow of RBC traffic in that territory. So I'm going to stop sharing here for a moment and take it back to the panelists and colleagues. What do you know about SSO2? What do you guys think about this? Is this sort of a credible? We'll get into the data here shortly, but you know, is this approach, you know, sort of, does it resonate in terms of all of the other things that we do for these patients? Jerry, you haven't weighed in yet. I'd love to get your perspective on this.
Yeah, thank you, Sandeep. It resonates with me because I think there's a significant gap, and the gap is what can we do for all patients to minimize what is an unfortunate natural history, right? That 20% heart failure is a deadly syndrome. And with micro circulation, obstruction and flow being the culprit, what can we do to improve flow? And so when I look at the data, and as you walk through the mechanism, think about the beneficial effects with less edema, less wall tension, less infarct size. And, you know, I look forward to having the discussion about the implications from LV remodeling. There's an opportunity at the time when the heart is most vulnerable, that patient is most vulnerable, to alter the natural history. So for me, that biologic plausibility, linking to what contributes to progressive heart failure, infarct size, wall tension, neurohormonal activation. Preventing that is key. And I don't think we highlight that enough. And I agree with Dan, as a heart failure specialist, we can get involved in select patients, but having the good fortune to influence the trajectory is key in my mind.
I would like
Right.
to emphasize, though, the mechanism here is not treatment of so-called reperfusion injury. And I think there's, in my mind, I don't know what you think, Dan and Sandeep and others, but that's the natural thought process here is, oh, this is a reperfusion injury tool, and we're going to get after reperfusion injury. In my understanding of this tool and looking into it, this is not reperfusion injury. This is actually better reperfusion, where we can actually really reperfuse the tissue. And that's where the mechanism really lies, just to kind of correct that initial thought that people might have.
Yeah, I 100% agree. I mean, I think that this should be viewed as an adjunct to what we're already doing in the cath lab, even when you think that things are going very well. And I'll put some numbers to that because I think that, we have a couple of hundred folks dialed into this call. I'm certain that somebody's sitting there rolling their eyes saying that, TIMI 3 flow means that the patient's going to have a good outcome. And that may or may not be true. And I think the other point that we have to sort of come face to face with is that we're not that great at predicting who does well because, 1 in 5 makes this a very common event, heart failure after a successful PCI. Certainly when you've got TIMI 0 flow or you've got TIMI 1 flow and all of the branches are gone, we know that that person's going to have a very large scar burden despite stent optimization, intravascular imaging, glycoprotein inhibitors, pulse spray vasodilators, and so forth. But what about the folks that we would predict would actually have a really great outcome? So I'd like to share with you a couple of additional slides here. This is what mortality looks like in the face of dropping door to balloon times. Now, Marat started this conversation with a slide that's, I think, interesting and provocative because, when you see a flat line that spans over a decade in the management of anterior STEMI, you kind of scratch your head and say, well, that doesn't really square with, what I see in my own practice or what I was sort of led to believe. We've made so many advances over the past 10 to 15 years. Well, here you go. Here's almost 100,000 primary PCIs at over 500 hospitals from the CAP PCI registry. And from the time of the door to balloon initiative, get with the guidelines and so forth, we've all gotten better at getting that vessel open faster and faster. It's sort of a badge of honor. How quickly can you get this done in a technically satisfactory fashion? And so, door to balloons have dropped from 90 plus minutes to 83 minutes, 76, and so on and so forth, to the national median, which is somewhere in the low 60s, but in hospital mortality and 30-day mortality have remained largely flat. So clearly we're missing something. I think, the natural reaction to a slide like this is that, well, we haven't really educated the public enough to know that total ischemic time is going to drive outcomes to a large degree. So if you sit at home with your anterior STEMI for many hours before you seek medical attention, well, obviously we can't really fix that with a fast door to balloon time. But I think there's more to it than that. And so let me share with you, I introduced the concept of SSO2. This is what is at stake. There's a 26% relative risk reduction in AMI-HOT 1 and 2 in patients with less than 6 hours of ischemic time, 26% relative reduction in infarct size. That translates to a 6.5% absolute risk reduction in patients who have PCI plus SSO2. And to sort of take a step back here, the protocol has evolved a little bit. What is currently being used vis-a-vis AMI-HOT 2 is a 60-minute infusion after completion of successful PCI of the LAD, which is the culprit vessel for the anterior STEMI that you're treating. And Marat already alluded to this. Indeed, 1 in 4 people who have primary PCI for STEMI, this is inclusive of LAD, circumflex, and RCA STEMIs, the majority of them, about 60% anterior STEMIs, if you break this up by quartiles, 25% of these patients have a residual infarct burden of greater than 30% of their LV mass. And even small changes in infarct size potentially translate to substantial reductions in the risk of mortality. And, you know, I sort of alluded to this a few minutes ago. It's not just the people that we think are going to do poorly that we should be treating. Michael, I think, very importantly pointed out that this is not treating reperfusion injury or no reflow. This is proactively treating patients that you think, maybe correctly, maybe incorrectly, are going to do well after primary PCI of their LAD. And so the overall AMBI 1 and 2 pooled populations, less than 6 hours, 26% relative risk reduction in infarct size. But greater infarct size reductions were observed in certain patient subgroups. So the folks who had anterior STEMIs and less than 3 hours of ischemic time, you would say that, okay, short ischemic time, they should do great. 41% relative risk reduction. And if you had pre-PCI TIMI 2 to 3 flow, these are patients already have some trickle of flow. They're not TIMI 0 at the beginning. These patients also benefit from SSO2. So I'm going to stop sharing now and take it back to the panelists and ask them what their thoughts are about this. Do you sort of, I look at this and I sort of view this the same way I look at the hypertension data. We're sort of at the cusp of renal denervation, and we're realizing that even small differences in blood pressure may translate to big differences in terms of cardiovascular morbidity, LV dysfunction, heart failure, and so forth. So Dan and Jerry, how do you, and Murad, how do you guys think about this this data?
Well, I maybe give it a first shot. You know, I'm amazed. I have sort of this outside view. I do my cath procedure, but I certainly don't do stents. You know, I'm amazed that at 20, 30 years, there's been no study that actually was able to demonstrate a reduction in infarct size and improvement in, you know, in the related microvascular disease, and it, you know, only had to take time to come to SSO. So I'm sort of asking now, you guys, why did it take so long to get to where we are right now to use SSO therapy? You know, did we just think differently or the wrong way about reperfusing tissue, and we just had to shove more oxygen down there in the first place? Now, but you know, I am amazed it took us so long to get here. I mean, the data is, you know, finally you have data. From what I understand, this is the first study to actually show infarct size reduction, which wasn't the case before. Is that right, Sandeep?
Yeah, I mean, I think it's finding the right concentration. I think the technology, you know, not to geek out on the actual, you know, mechanism of action and technology, but it is a pretty amazing technology because you're creating aqueous O2 at room temperature and reinfusing it without it bubbling out. And so that alone is a technological hurdle. If you look at the history of SSO2, the preclinical data actually spans about 2 decades. So this has been brewing for about 2 decades to actually get to a situation where it is easy to use, reliable, reproducible clinical outcomes. And so, you know, I showed you that, showed everyone that slide. You know, there have been numerous approaches, and I think it's really tantalizing to think about combination therapies also. Another very important therapy that's on the near horizon, perhaps, is left ventricular unloading, mechanical unloading, and so it's sort of tempting to think about, you know, how best we can combine all of the different therapies that we offer these patients. There's a question in the chat that sort of touches on risk factors or you know, easily identifiable clinical risks that enhance the risk for adverse LV remodeling afterwards. So, you know, for our heart failure colleagues, are there other risk factors where we look at somebody and say, independent of the angiogram, this is somebody who's really going to have trouble after the index event? And
I can start.
Look at BMI and some other conventional cardiovascular risks.
Yeah, the specific questions were about age and BMI. To my knowledge, I don't know that there's specific data about BMI. Of course, older patients are generally at risk for worse outcomes due to comorbidities, et cetera. But in terms of the issue of remodeling, which was brought up a few times, that is a lot of what we're dealing with here. We want to prevent that adverse pathological remodeling, which really underlies the development of heart failure. And as we know, like, beta blockers, for example, are a class 1 indication in the setting of AMI, not when patients are not in shock. And why is that? That reduces infarct size. When you reduce heart rate, you reduce contractility a little bit. When you're not in the setting of shock, these things reduce oxygen demand from the myocardium. And when you're in a setting of limited oxygen supply, every little bit of oxygen counts. So if you can save oxygen by reducing heart rate and reducing contractility, you're going to reduce infarct size, and we know that. But after that, a lot of the drugs that we give afterwards, like were mentioned, like MRAs and other things, are meant to also prevent or limit remodeling. They don't really address the issue of continuing to reduce infarct size, because the window of opportunity is really in this short period of time when you are, in the ischemic time, in the time, from before you've opened the artery to after you've opened the artery, you only have an hour, 2 hours or so, because myocardial necrosis occurs within that time frame, and by 6 hours, I believe, the infarct is complete. So you only have this short window of time to get oxygen to the myocytes. That's what it's really all about. So you can't do your procedure and then hope that you're going to give something, a couple hours later, that's going to continue to prevent the infarct expansion and actually the progression of the infarct. That's why this time of administration of the SSO2 to get oxygen, to open up the microvasculature and get oxygen to the myocytes is so critical. You don't have, it's not, once you leave the cath lab, you're nearing the end of this window. And what you're doing after that period is to prevent the remodeling, not to reduce the infarct size. You're just trying to prevent the remodeling, which is driven by, the size of the infarct, the hemodynamic forces, and the activation of the neurohormonal system, increased sympathetic tone, which is driving, trying to maintain normal hemodynamic parameters. So you can't expect for therapies that are administered later on to reduce infarct size. And I think it is important to reemphasize what Michael said. This is not reperfusion injury. This is really reducing ischemic burden even after epicardial flow is restored.
So
Yeah, I think those are 2 points. Jerry, you want to build on that?
Yeah, no, I think, the question was about risk factors, and the way I think about it is that, certainly, age and female, and I would add, I'd be concerned about diabetics, but I think it's important to highlight that all patients having an ST elevation MI are at risk, and it's hard to predict whom was going to have the greatest degree of infarct size or adverse alveolar remodeling. And so, in heart failure, we're trying to put more emphasis on earlier stage disease. Like stage A is those patients at risk for heart failure with reduced EF, hypertension, those with coronary artery disease. And so every ST elevation MI is at risk. And so I think it's key, while yes, there's an opportunity to further define who's at greater risk, all these patients are at tremendous risk in my mind. And not knowing how to, manipulate, based on a risk profile. What I like about this therapy is that it's getting at the common denominator for all those patients related to microflow obstruction and infarct size and adverse remodeling. And so I very much like how Dan is highlighting this gap, this opportunity of treating early to prevent the syndrome, to prevent the problems. And certainly infarct size, degree of alveolar remodeling are surrogates for adverse outcome. And so I think that's critically important as we're rethinking what can we do to improve upon these flat in-hospital and 30-day mortality curves. And in my mind, it's being cognizant of the denominator of this patient population.
Yeah, those are all excellent points. I'm going to put up one slide here that I think once again just sort of underscores that this is not just about definitional differences and outcomes in a clinical trial. SSO2 in several studies have actually shown to enhance LV recovery at 30 days, and this is actually being measured as LV volume. So, on a very prosaic level, we all sort of obsess about ejection fraction and how the patient's doing. Of course, very important. But in addition to that, the adverse geometric remodeling of the left ventricle after a big ischemic insult is another issue that needs to be tackled. And so, SSO2 does seem to have a meaningful effect on reverse LV remodeling within 30 days. I'm gonna just sort of throw this at the interventionalist, because I think that there's a lot of folks who buy into the science and the trial data, but when it comes to actually spending an extra hour in the cath lab at 2 a.m, it gets there's a lot of wrinkled noses at that point. I view this in the same sort of spectrum of other things that we spend time on in the cath lab to get better outcomes. So intravascular imaging, calcium modification, post-dilatation, having some sort of algorithm for approaching complex lesion sets and so forth. Michael and Suzanne, how do you sort of think about this value proposition, and is this sort of a light of day thing, or is this something that we should be perhaps offering to everybody when they come in with an anterior STEMI?
So I'll jump in on this. Look, I'll admit, right? Like, nobody says, hey, what do I want to do at 2 a.m. is, hang out for an extra hour, and your staff doesn't want that either. But I think this really comes down to, the first cut is the deepest here. And we have this window of opportunity to really make a difference for the future for this particular patient. And you kind of touched on this earlier, saying that, we're not even just thinking about the individual patient, it's also looking at society. I think we can all agree our healthcare system is certainly economically stretched and strapped. If we can do something that can improve outcomes and then also improve, how our healthcare system is evolving over time, down the road, I think that these are really big things. And we have this very small window of opportunity to be able to do it. So if we're going to look at all the other quality metrics, and as you mentioned, Sandeep, the things that we do to try to optimize our PCI outcomes, I think we need to consider, that this has to be within that toolbox for that. And, it doesn't matter if it's 2 a.m. or it's 2 p.m. We are a 24-hour, 7-day-a-week cath lab, and that's how we have to view this.
And I'll just add on to what Suzanne just said. We're a 24-hour cath lab, but remember, it wasn't that long ago where cath labs weren't 24 hours. So we had many hospitals across this country that did not provide 24-hour care for STEMIs. Thrombolytic therapy was given, and there was an adoption to move toward primary PCI because it was a superior treatment. And then to do that, we had to be able to figure out how to get 24/7 call teams for cath labs. We had to figure out how to manage that and appropriate the workforce, the space to manage things for best patient care. And I think this is the next step. We bring up the fact that 2 a.m. because in our minds, that's the worst possible time. But that's not when the majority of STEMIs actually happen. They're all across the spectrum, as Suzanne just said. So, I would look at it in terms of it's really, I think, a time now to broaden our focus. We've micro-focused on door-to-balloon time, and I think we've gone as far as we can with that. It's time to broaden our focus, trying to save as much myocardium as possible. And I don't know committed cath lab techs, nurses, or interventional cardiologists that when faced with the question of this therapy will take another hour of your time, but will actually improve your patient's outcome, almost all of them will jump at it. And I think that's the proposition we need to put forward.
Well, maybe some
Great.
additional
Murat?
points. There's a heart failure epidemic out there. We have way too few heart failure docs, way too much heart failure out there. And this is one of the driving forces for new incident heart failure in the future. And medicine in the United States and globally is moving to value-based care. You're responsible for that patient, not only clinically right then and there. And, Dr. Barron mentioned earlier, the episodic care, but the patient's outcomes at the 30-day, the 90-day mark will cut into your bottom line. If you think just from a financial standpoint alone, it will make case. If you have a therapy that can improve upon the short, mid, and long-term outcomes, even if it comes from an upfront cost, whether it's actually money or time, and I'm sorry for you guys that PCI is happening at 2 a.m. in the morning, sorry, not sorry, but it is what it is, that's when we have to deliver that care. And I think that healthcare systems probably will push it in that direction as well. I mean, to where if there's something upfront will reduce the cost down the line, I think it makes sense. The healthcare system makes sense to the clinician and the patient.
And with that, I want to share with you a couple of slides that you may or may not have seen. And this is particularly exciting because as we think about new technologies, we always kind of scratch our head and say, well, this thing worked in a very rarefied, picked over clinical trial population. We're all clinical trialists. We know that clinical trials often don't mirror what comes in through our ER or cath lab or our CCU in real life. And so there were a couple of real world analyses presented at ACC this year and the SCAI meeting in Phoenix that I think gives us a lot of confidence that this is a therapy that is easily reproducible in a variety of practice settings that result in meaningful improvements in left ventricular ejection fraction. And so this is from Corewell Health, looking at SSO2 treated patients versus PCI patients. Non-randomized comparison, admittedly, but this is a real-world comparison. And I think for everyone on this call, they have to recognize that less than 1,000 commercial SSO2 cases have been done. I mean, if it's more than 1,000, it's not much more than 1,000. So this is really kind of a novel therapy in the U.S. practice space, and so it's encouraging to see little bits of data like this. Where patients, about 50 patients or so, a little over, show a 15% improvement in ejection fraction at 1 month, and then 21% at 3 months. Similar data from the group in Miami Cardiac and Vascular Institute, presented at SCAI, once again showing meaningful improvements in ejection fraction with SSO2, more modest gains with conventional PCI, all the techniques that we would use appropriately for anterior STEMIs. Very exciting. Heart failure hospitalization in HFrEF patients. In these patients, 15%, not quite 1 in 5, but pretty substantial. 0% in the SSO2 group, 0% rehospitalization, stroke mortality, ICD implant, or reinfarction in that group. Again, small bits of data, and there's a lot more to follow. And a couple of important registries are underway, being led by Dr. Burkhoff and others, to actually gather real-world data as we sort of roll out SSO2. In the last few minutes that we have, I'd like to just sort of poll the group and ask a fairly broad question. How do we sort of move the needle now? How do we sort of bring this forward and get more of our colleagues to sort of understand the data and the value proposition here and implement this in cath labs around the country? I know that's an excessively broad question, but I think it'd be worth getting everyone's ideas on this.
So, Sandeep, if I may,
can start. Go ahead, Jerry. Go ahead.
I was going to highlight that, patient-centered care is key, and it's based on achieving the best quality and as safe as you can do it. And I think that resonates for all physicians caring for this patient population. And if you can improve upon the quality of that patient, and then I like Murat's comments about value-based care, and you can look at your hospital, your system. I think the time has come to see this as a team approach, as opposed to just a cath lab opportunity. And so I think it's providers, and that's from techs to cath lab personnel to the interventionalists, in collaboration with heart failure specialists, and closing the gap, I think, about this quality proposition. So that's what it is. It's a quality proposition with a low at-risk profile that I think makes sense. And then, so that's how, so certainly when I reflect on our ongoing conversations, it's about doing better for an individual patient, for these types of patients in general. So that's how I would start the discussion.
Other comments or perspectives?
So from my perspective, introducing a new therapy into clinical practices is always challenging. And especially when it's device-based and it involves extra work, shall we say, on the part of the clinician and the supporting staff at the hospital. So I think a lot of it is driven by awareness and additional data. So I think the more data we can collect about this therapy, that is high quality data, and the more we can be on podiums talking about the therapy, and also getting peer-reviewed papers in high-quality journals will really be convincing to people to to use this therapy. Of course, the real challenge, and again, this is difficult for any new therapy, especially device-based, is getting into the guidelines, and that I think is a task that is quite formidable, but is something that I think that those of us that are on the believe in this approach, from the data that are available, we need to double our efforts to generate more data that will get the attention of the guideline committees, if nothing more, to get them mentioned in the guidelines as a consideration, and really just that will keep our eye on the focus of just generating more data.
I think that's right, Dan. And there's a question that just popped up that I'll emphasize. Sandeep mentioned there's only been 1,000 cases, maybe a little bit more commercial cases that are done. We're very early in this process of SSO2 therapy. Jim Spears certainly spearheaded this in Detroit and has been working on this for decades. The question says, has anyone used SSO2 demonstrated accelerated improvement in persistent ST elevation following PCI? And Jim's shown several cases in his own personal experience where you have persistent ST elevation with an open epicardial vessel, and the administration of SSO2 actually reduces symptoms and ST elevation. And the generation of data, the sharing of these types of experiences of how it works, the development of better practices. Because you didn't bring this up, Sandeep, but most of us are doing our STEMIs on a radial approach, and the SSO2 therapy is not best suited to be delivered radially right now. But trying to move this forward and trying to figure out how to better do this. What's the optimum patient? What's the optimum duration of SSO2 infusion? All of these things are ripe. And so I think, to me, the purpose of this call tonight, and I appreciate everybody who joined in and all my co-panelists, but we're trying to encourage people to jump on the bandwagon and help move this process forward. And we need everybody's help to figure out the next frontier in STEMI care.
Well, I think that's an excellent summary. We're right at the top of the hour, so I think we'll end it there. I'd like to thank once again my co-panelists, Dr. Burkhoff, Dr. Estep, Dr. Fudin, Dr. Mike Lynn, and Suzanne Barron, and as well as all of the folks that tuned in tonight. Big thanks also to Radcliffe, as well as to Zoll Medical for sponsoring this event. Thank you, everyone. Have a good evening.